Okay, so for the part two of the herpes virus infections, for the viral infections, we will be talking about the herpes virus. So herpes virus belongs to herpes viridae. It's one of the largest DNA viruses. There are many types of herpes viridae, but we will only be discussing the Epstein-Barr virus, the Cytomegalovirus, and the varicella zoster virus. Okay, so let's start first with Epstein-Barr virus. So do you know that Dr. Epstein and Yvonne Barr, both of them discovered, the Epstein-Barr virus. And this particular DNA herpes virus causes a spectrum of diseases. So they can cause infectious mononucleosis, sometimes known as the kissing disease. Why kissing disease? Because this one is common among teenage men or women who has multiple kissing partners. And the reason why it's called kissing disease because it is mostly commonly transmitted by intimate contact with salivary secretions. So aside from infectious mononucleosis, they can also cause the lymphoproliferative disorders and certain malignancies such as Burkitt lymphoma. If you could still remember your hematology, yung Burkitt lymphoma is actually the FAB-L3. Diba yung acute lymphocytic leukemia has three types, L1, L2, L3. And then L3 is connected with this one. So the infection begins in oropharynx, particularly in B cells. So B cells is actually the site of latency. So again, when we say latency, this is the stage where the virus is hiding. Okay, so it begins in oropharynx in B cells, epithelial cells, and it will spread through the lymphoreticular system. Okay, so let's talk about the markers. Okay, so during the early acute phase, these are the markers, no? So we have the EAR, which is the early antigen restricted, and then the early antigen D diffuse. So this is the early acute phase. Now, during the late phase, the markers are the viral capsid antigen or the VCA, and then the MA or the membrane antigen. During the latent phase, the markers are the EBNA, Epstein-Barr nuclear antigens, which divided into 6 types, 1, 2, 3, 4, 5, and 6, and the latent membrane proteins, which is divided into 2 major types, and LMP is divided into 2A and into 2B. Okay, so these are the different markers that we are using. Infectious mononucleosis is a common manifestation. It's a common manifestation of Epstein-Barr virus. So the classic symptoms would include having a fever, lymphadenopathy, sore throat, and fatigue. So laboratory findings would be acute lymphocytosis, wherein more than 20% would have the atypical lymphocytes. If you remember your hematology, the WBC anomaly, this one is known as the Downey cells or the atypical lymphocytes, which is one of the hematologic findings for having an infectious mononucleosis. And of course, there would be a positive heterophil antibody, which can be diagnosed through the Monospot test, Paul-Banel test, and rapid agglutination test. So heterophil antibodies or the Monospot test, okay, is the one of the tests that we can determine infection with infectious mononucleosis. So it has a very high sensitivity between 90 to 95% after first week, but the sensitivity will become very low, okay, during the first week. So you need to wait. You need to wait for a week, okay, to to decrease the chances of having a false negative result. Now, the specificity for infectious mononucleosis monospot test is 94%. Okay. However, false positive may also be seen in cytomegalovirus, toxoplasma gondii infection, and acute HIV, malignancy, and having an SLE or systemic lupus erythematosus. Okay. So because of this, this particular test is no longer being advocated by CDC because of a confusing false positive and false negative result. But at any rate, the monospot test will determine the IgM antibodies against the viral antigen which has been absorbed in RBC. So so there would be positive agglutination test. Okay. So a heterophil positive serum is characterized by clumping, and a heterophil negative serum means that there is no clumping. So this particular method is also available in immunochromatographic assay. So in order for us not to get confused, these are the serological responses of patients with EpsteinBarr virus. So if you notice, those patients who are uninfected will be negative in all of the markers. But patients with acute infectious mononucleosis would be positive with both IgM and IgG and would have variable results with other markers. Patients who are in convalescent stage would be positive with IgG only, but negative with IgM. Okay? And noteworthy to mention as well that they are also positive in anti-EBNA. Okay, what's the difference between a convalescent and past infection? The difference would be in the variability in the heterophil antibodies. So usually, convalescent infectious mononucleosis would have a variable result in heterophil antibody IgM, but it's absolutely negative in patients with past infection. Okay, for patients who are in chronic active infection with infectious mononucleosis, they will be highly positive in anti-VCA IgG, positive in early antigen diffuse antibodies against early antigen diffuse, double positive for early antigen restricted. For patients who have received transplant, post-transplant due to lymphoproliferative disease, so they would have almost the same clinical picture with chronic active, no? Except that yung grading ng positive result lang magkakaiba. Ano bang ibig sabihin ng +1, +2, +3, and +4? We are referring to the grading of agglutination. Wherein, pag sinabi nating +4, if this is the field, 100% of the field is agglutinated. So that's what we meant by +4. Okay? So, pero among this, the highest grading that you can possibly see are the +3. So, almost similar markers, almost similar picture of the markers for these states. Okay? So, these are the serological responses of patients with Epstein-Barr virus infections. Okay. So, Cytomegalovirus. This one is another significant type of virus. It's a DNA herpes virus transmitted through oral secretions, genital secretions, congenitally or by transfusion or transplantation. So, cytomegalovirus is one of the infection that we are measuring in torch test, which we have already discussed from the last week's lecture. So in healthy individuals, you could be asymptomatic, or it may mimic a mononucleosis-like syndrome for healthy individuals. However, for those individuals, with 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 HIV or AIDS, okay, it can disseminate to lungs, livers, gastrointestinal tract, central nervous system in eyes, and cause a life-threatening infection. Why? Because for immunosuppressed persons or persons with debilitated immune system, it has become systemic. So the infection has become systemic. So this one is teratogenic, meaning to say it may destroy, it may damage fetus, it may cause congenital defects and decrease the survival of infants. So that's what we meant by teratogenic. Okay, so how do we detect cytomegalovirus? We can do viral culture, but we cannot do it on a routine basis. So for the viral culture, we can do the human fibroblast cell lines whenever we inoculate it with the CMV infected specimen and the presence of CPE. Okay, so CPE or the cytopathic effects. The cytopathic effects are the cytopathic effects are the pathologic changes. Okay, when you say CPE, this is the pathologic changes in the morphology of cell culture. So that's what we meant by the CPE. So usually, this can be done through a cell vial culture. We can also identify the cytomegalovirus antigen. So we can do the CMV antigenemia assay or the presence of antigen in the blood or immunofluorescent staining. So molecular test for CMV DNA is done also through PCR. So this will determine the viral load. Okay. So there are also serologic assay for cytomegalovirus. There are assays available for CMV IgG, CMV IgM, and the serial assays. So again, as a rule, when you say IgG, this actually will determine the past infection. Okay, this one will determine the acute infection. However, in serial assay, the IgG and the IgM assay is further classified whether it is a low avidity or high avidity. So for example, if it's a low avidity IgG, it will determine the recent infection. But if it's a high avidity IgG, it will determine past infection. Now, a combination of IgM and low avidity IgG is actually is actually useful, particularly for assays of pregnant women who contracted a primary CMV infection. So this one is useful for screening of pregnant women. We do not want pregnant women to get infected with CMV because of the possibility for teratogenicity. Okay, so and then we also have here the varicella zoster virus. So it's another example of a DNA herpes virus. So again, this one causes varicella causes chickenpox, and herpes zoster causes shingles. And shingles is a latent infection of chickenpox. So this particular type of virus is transmitted by inhalation of infected respiratory secretions or aerosols from skin lesions. So the primary infection is the varicella zoster virus, which will travel from skin lesion and the blood to the sensory neurons. Okay? So so having a shingle is actually more painful than chickenpox. You know why? Because the site of infection is in sensory neurons or sometimes in the peripheral nerve endings, which is our pain receptor. And I've talked to a person with shingles, and she described to me how painful it is. And you know the description, it's like you have a wound and then someone with a hot blade lacerate your wound. That's how she described shingle. And varicella zoster is actually a reactivation. It could be reactivated, meaning to say, you had chickenpox in the past, and you thought all the while that you have fully recovered, not knowing that the virus is just hiding in your peripheral nerves. Luckily, fortunately, this can be prevented through vaccination. So varicella zoster can be prevented through vaccination. So diagnosis is usually based on the characteristic of clinical findings. Viral culture can be performed, but it is not recommended since it is not practical. Chunk test can be done by getting the smear from the infected vesicles, but you have to be careful. And then you stain it. And the presence of a chunk cells would indicate actually this in some text it's like this, the spelling's like this. So so the presence of a chunk cell would indicate that there is indeed the presence of a virus. Okay. Molecular testing is also a possibility. So we can do the direct immunofluorescence staining or scraping against the VCV antigen or the real-time PCR. So this one is the method of choice, and it is being used to monitor the response to antiviral drugs. Serological testing is limited and it is useful in determining immunity. Okay, because this will determine whether you have the antibodies, which could be either IgG or IgM. Okay, so other viral infections would include in this particular lecture the following. No? First, we have the rubella virus. So the rubella virus is an RNA virus transmitted through respiratory droplets or across the placenta. This one is the etiologic agent of German measles and can cause abnormalities, congenital abnormalities, miscarriage, and stillbirth in infants born to infected mothers. That is the reason why it is part of the torch test. Okay, this one is preventable also through transmission, through immunization. So laboratory testing for rubella could be viral culture. This one is time consuming, labor intensive, and not practical for routine purposes. We can also do RT-PCR, which can detect the viral nucleic acid. This one is also expensive, okay, and not practical unless there is already an epidemic. So the most common test that we're doing for rubella is a serological test to determine antibodies against the rubella, particularly sometimes for pregnant women as well. So this could be through hemagglutination inhibition, latex agglutination, immunoassay, or immunochromatographic assay, such as the one shown in the illustration here. Okay, rubiola. Rubiola is the etiologic agent of measles, which is different from German measles. German measles is caused by rubella, okay? measles caused by rubella. It's another RNA virus transmitted through respiratory droplets. Do you know that measles are actually not as complicated and severe or grave as its consequence? Okay, the complication of having measles are actually more fatal. And this is known as the SSPE, or the subacute sclerosing panencephalitis. Before the COVID-19 pandemic, there was this, during the time of the Vaxia scandal, there was this vaccine scare among mother. They didn't want their infants to get vaccinated. Hence, cases of measles in our country increased up to 200%. So, because that is not a good scenario, because, rubella or measles can be prevented through immunization as well. So, diagnosis is usually based on clinical presentation and can be confirmed through serology. So, the viral culture is not performed during routine diagnosis, but serological test is more practical and reliable. So, during the acute phase, there would be IgM, and the one that is considered to be as significant is the four-fold rise of the IgG titer, 10 to 30 days of interval, of specimen collection interval. Molecular method is used for genotyping, particularly if you are not confident with the serology report, then we can resort to molecular diagnostics such as the RT-PCR. But then again, it is not practical for routine purposes unless there is an epidemic. Okay, mumps. Okay, it's an RNA virus transmitted through respiratory droplets, saliva, and fomites. So the most common clinical manifestation is infectious parotitis, wherein your parotid gland is inflamed. So that is the reason why, hello? That is the reason why, since your parotid gland is already inflamed, and that is the reason why it's swollen, no? And sino-sino ba yung mga nabudol dito ng bata nung ang gamot daw sa mumps is yung blue dye na may suka at mabaho at nilagay dito? Actually, that is not true. Okay. Do you know that you do not want to get mumps when you are adult already? Because the complications of mumps is orchitis. This is the inflammation of the testes. And for women, it is ophoritis, inflammation of the ovary. Both of these could result to sterility. So you do not want to get mumps. You do not want to get mumps if you are adult. Okay? So maganda, when you were still a child before, dapat meron kang MMR, measles, mumps, rubella. So this is the vaccine that will prevent the infections that I just mentioned. So the diagnosis is usually based on clinical presentation. So we can do culture. It's a gold standard, again, but it's not practical for routine purposes. We can do RT-PCR, but then again, it's not really practical because it's expensive. Genotyping will track transmission during epidemics. So for routine purposes, the most commonly used method is the ELISA. The different platforms are available, such as ELISA or the solid phase IgM capture, which will reduce the incidence of a false positive. So again, just like in any other assay, the presence of IgM will indicate current infection, and IgG will, particularly a four-fold rise between two specimen collection with an interval between 10 to 30 days are considered to be as significant. Okay, and then let's talk about the HTLD. Okay, the human T-cell lymphotrophic virus 1 and 2. So it is a retrovirus, just like your HIV, that can infect your CD4 and it is transmitted mainly through bloodborne or bloodborne sexual contact, and it could also be perinatal. Okay, it is the cause of adult T-cell leukemia and lymphoma. It is HTLD1 associated myelopathy, tropical spastic parapeers, and other inflammatory disorders. So this one is the only virus that can cause leukemia, HTLV1. And then the other one is HTLV2. There is an unclear disease association, but as you can see in the illustration, it can cause T cell tropism. When you say T cell tropism, the tropism, when you say tropism, the cells where the virus is currently at is not the original cell when the virus enters the body. That is not the original host cell. Okay? So these are the infections that can be caused by HTLV. And just like your other viral infections, the most practical way of diagnosing HTLV would be by means of ELISA and CLIA, chemiluminescent assay. However, the confirmatory test is the Western blot assay. But molecular testing is more useful, particularly if the result of serology is not reliable, particularly for monitoring the viral load during the therapy. Okay, so that's the end of our lecture. I will be uploading the PowerPoint, and I want you to study the case study and the journal critique, okay, in the PowerPoint, because that would be part of your final assignment. Okay, so thank you very much.